Hi guys, good morning and welcome to today's session on rapid fire MCQs and surgery episode 1. Very good morning to all of you. I hope I'm audible and visible to you. Can I just have a thumbs up from you guys if I'm audible and visible? Okay. Let's see if we have the audience in the morning. Okay. Hi, good morning. Am I audible and visible to you? I hope I'm audible and visible to you. Right. Okay, I think I'm live and I should begin with this particular session. So guys, good morning. Today we are going to again have a look at a few important MCQs, few important concepts, and hopefully try to kind of conquer them bit by bit. So the first question which I have for you guys is, that there is a patient who is kind of let's say the patient was operated for Billrod type 2 surgery. Okay, so patient, let's say, had a kind of a gastric carcinoma and the patient was operated, let's say, for a Billrod type 2 surgery. Now what is happening is that the patient developed seizures, and after the patient had lunch, let's say 3 years before. Okay, so let's say there is a patient who is being operated for the Billrod type 2. Then in the post-operative period, what happened? The patient basically had the lunch, and after that the patient basically developed the seizures. When you basically did a serum blood glucose of this particular patient, it came out to be 40 milligrams per deciliter. What is the diagnosis of this particular patient? So what do you think, guys? What is the diagnosis? Is this particular patient suffering from early dumping syndrome, late dumping syndrome, duodenal stump blowout, or kind of anastomotic leak? So what do you think, guys? What is the answer to this particular question? So guys, if you're thinking in the terms of dumping syndrome, yes, you're right. And if at all you say that it is a late dumping syndrome, you're absolutely correct. So let us kind of understand the concept of a dumping syndrome, guys. Okay, so let's understand the concept of a dumping syndrome. Now what is this dumping syndrome? This is basically a post-operative complication which occurs after a gastrectomy. Okay, so now before we talk about this particular gastrectomy, let us kind of have a look at the normal stomach. So let's say there is a stomach which is present in you and me. So what is present at the end of the stomach? You have a pylorus. Okay, so you have a pylorus. So whenever you eat your food or anything, your food basically reaches the stomach, and then you have a gastric holding time. Okay, what are you having? You are having a gastric holding time, and this is usually around 2 hours. Okay, so you are having gastric holding time of 2 hours. But why this is possible? This is possible because of the pylorus. Now if at all you kind of get rid of this pylorus, let's say if at all you did a gastrectomy in this particular patient, so you will no more have a pylorus. If you don't have a pylorus, and let's say you did a kind of a Billrod type 2 reconstruction, gastrojejunostomy, if you did like this, every time you eat the food, what is going to happen? The food is going to come to the stomach and there is no pylorus, so it is immediately going to enter into the intestine. Okay, so I hope you appreciate the contrast. Over here what is happening, this is the normal individual where you have a normal pylorus, but here the food is being kept in the stomach for close to 2 hours. On the other hand, if at all you perform a Billrod type 2 surgery, let's say this is a loop gastrojejunostomy, here what is happening? There is no pylorus. So because there is no pylorus, as soon as you eat the food is leaving the stomach and it is entering into the intestine. Now, I hope everybody is on the same page till here. Now, it is safe to say that whatever the food is entering, we can refer it as a hyperosmolar. Okay, right, obviously, right? I mean, the food which is entering from the stomach into the intestine, it is hyperosmolar. And what do we know about the hyperosmolar substances? They attract the fluid. Okay, so now let us imagine this is the intestine of a person in whom there was no pylorus. So what happened? A large amount of the hyperosmolar substance came into the intestine. Large amount of the hyperosmolar substance basically came into the intestine. Because of this, what happened? There was a lot of fluid sequestration. And because of this fluid sequestration, what happened? The patient landed up into diarrhea. Okay, so because of this, the patient landed up into diarrhea. So this is what we refer to as a early dumping syndrome. I hope I'm clear to you guys. So what is happening? Hyperosmolar substance is entering into the intestine. Because of this, the fluid is getting sequestrated into the intestine, and because of this, we are getting a diarrhea. This is what is referred to as a early dumping syndrome. This is what is called as the early dumping syndrome. Okay, so this is basically happening within 30 minutes. Like from the time you eat the food, within 30 minutes you are getting this diarrhea and everything. The patients will come to you with the signs of dehydration. The patients will come to you with the signs of dehydration. So this is all about the early dumping syndrome. But what we are interested in, talking about the late dumping syndrome. So let us talk about the late dumping syndrome, guys. So what is happening in the late dumping syndrome? In the late dumping syndrome, so the mechanism is kind of similar. Here again, a hyperosmolar substance is reaching the intestine, but here what is happening, there are certain receptors which are present in the intestine. So as soon as your hyperosmolar substance reaches the intestine, these receptors get activated, and these receptors basically go to the pancreas. Okay, they basically go to the pancreas and tell the pancreas, you know what, there is a large amount of hyperosmolar substance which has reached the intestine, so you better secrete a lot of insulin. So these hyperosmolar substances, they stimulate the receptors. Because of this, the pancreas, this is kind of told to increase a lot of insulin, so that whatever these hyperosmolar substance, when they get absorbed, the glucose can be taken care of. But as we know, these hyperosmolar substances, these are not getting absorbed. These are basically kind of getting rid in the stool. Okay, they are not absorbed. So because of this, what is happening, there is a relative excess. Because of this, the insulin, this is basically present in the relative excess, and because of this, we land up into hypoglycemia. So I hope you get this particular stuff. So this is basically like, it takes around let's say 1.5 to 2 hours after the like the food is ingested for this to happen. So yeah, this is the mechanism of a late dumping syndrome. So what we have mastered is, we have mastered the concept of a early dumping syndrome and the late dumping syndrome. In the early dumping syndrome, what did I tell you? That because there is no pylorus, hyperosmolar substances are entering into the intestine. Because of this, the fluid is getting sequestrated. Because of this, the patients are landing into a diarrhea, and the patients come to you with signs of dehydration. This is happening within 30 minutes of eating the food. This is what is called as the early dumping syndrome. On the other hand, when these hyperosmolar substances reach the intestine, they stimulate the receptors. These receptors go to the pancreas, where they stimulate the secretion of insulin, so that whatever the food, if at all it gets absorbed, it can be taken care of. But in this particular patient, the food is not getting absorbed. So that is why the insulin is actually present as a relative excess, and this is why the patient lands up into hypoglycemia. Okay, so I hope you got the concept of early and the late dumping syndrome. Moving on to the next question, guys. According to the Bollmans classification, Linitis plastica is, okay, so can you please help me, guys? Linitis plastica, is it type 1, type 2, type 3 or type 4 according to the Bollmans classification? Can you please let me know, guys? What is it? So according to the Bollmans classification, what is a kind of a Linitis plastica? So guys, if you're saying that it is class type 4, you are absolutely correct. So let us kind of quickly understand the Bollmans classification. It is very simple. You will understand it like within a minute. So type 1, what is type 1? It is basically polypoidal. Okay, so it is basically polypoidal. Here what is happening, if at all, let's say there is a kind of lesion which is like a polyp, that is what is called as a type 1. You classify it as a Bollmans type 1. In the type 2, what is happening? It is ulcerative. So here what is happening, there is a ulcer type formation over here. So in the stomach, if at all you have a lesion which is leading to a formation of a kind of ulcer, it is called as a Bollmans type 2. In the Bollmans type 3, what is happening? It is what is referred to as a ulceroproliferative. So here what is happening, guys, there is formation of an ulcer, no doubt, but at the same time there is also the proliferation in the wall of the stomach. So this is what is referred to as a ulceroproliferative lesion. Please understand, ulceroproliferative, that is Bollmans type 3. And in the Bollmans type 4, what we have is predominantly proliferative lesion. So here what is happening, let's say this is the wall of the kind of stomach. So here what is happening, there is a lot of proliferation which is happening. So because of intense proliferation, this particular stomach, it behaves like a leather bottle like feature. What do you understand by leather bottle like feature? It means that it is non-distensible, it is kind of non-deformable and everything, and this is what you refer to as a linitis plastica. Okay, this is what is called as a linitis plastica. Okay, I hope I'm making sense out of here, guys. So it is very, very simple, don't worry, but it is a very, very important classification which you need to understand. This is what is called as a Bollmans classification. And yeah, you guessed it right, this is basically done for the gastric carcinoma. For the gastric carcinoma, which the classification system which we have is a Bollmans classification, and I hope it's clear now. Okay, so polypoidal, ulcerative, ulceroproliferative, and predominantly proliferative lesions. Okay, great. Moving on. So routine management of a paralytic ileus. So yeah, paralytic ileus, it is a complication which can occur after the surgery because the intestine did not regain the peristaltic activity, and because of this there is a kind of ileus, that is a loss of peristalsis. Because of this, the patient is presenting to you with something which is called as a dynamic intestinal obstruction. So what do you understand by dynamic intestinal obstruction? It means that there is no physical obstruction. All you are having is a loss of peristalsis. Because of this, you are getting features like a intestinal obstruction. Okay, I hope you understand this particular concept. It is important. Now what I'm trying to ask you over here is that if at all you get a patient with a paralytic ileus, you will manage, like the routine management includes all of the following except. So electrolyte correction, nasogastric aspiration, parasympathomimetics, and IV fluids. Okay, well, okay, now the routine management, it doesn't include the parasympathomimetic. Usually we don't prefer to go for that. Usually we try to go for like primarily we treat it by the triad of three things. So the most common cause for this dynamic ileus is electrolyte abnormality. So definitely you'll have to go in for an electrolyte correction, because this particular patient was having signs of intestinal obstruction, so that is why he must be, or she must be having a lot of dehydration. So that is why you have to definitely give IV fluids to this particular patient. And at the same time, because you don't want the stomach to be over distended and ultimately land up into gangrene, so that is why what you want to decompress the intestine, and because of this you go in for a nasogastric tube aspiration. Okay, so see, understand, there are a few concepts which say that parasympathomimetics can also be given, but that is at a very, very late stage. It is not a part of a routine management. Okay, so you need to understand these three are the integral part of the management of a paralytic ileus: electrolyte kind of correction, IV fluids, and the nasogastric aspiration. Okay, I hope you understand this. If at all the options are like this, you definitely have to go in for a parasympathomimetics. Okay, right, moving on. So next question is the starch iodine test. Okay, so I'm sure you must have heard of this particular test. What I'm trying to ask you is that this is used for what? Now, okay, is it used for the Wegener's granulomatosis, cat-scratch disease, sarcoidosis, or the Frey syndrome? Now, if you say that the answer is a Frey syndrome, yes, you're bang on, you're correct, you're absolutely right. What is this Frey syndrome, guys? What is this Frey syndrome? So this is basically happening kind of a post-parotid surgery. So in the post-parotid surgery, what is happening? Whenever the patient is eating the food, there is erythema in the skin overlying the parotid and sweating. When the patient is having food, weird, right? Yeah, when the patient is having food, why should the patient have erythema in the sweating over the skin, over the parotid region? The reason is because when you were kind of operating on the parotid, you accidentally damaged the auriculotemporal nerve, or let's say the surgeon accidentally damaged the auriculotemporal nerve. So okay, so auriculotemporal nerve was damaged, so what a big deal. So what is happening, guys? You need to understand that normally, normally in the auriculotemporal nerve, you have parasympathetic fibers which are supplying the salivary gland, and then you have a sympathetic fibers which are supplying the parotid as well as the sweat glands. So normally the sweat glands, they do not receive the parasympathetic fibers. But what happened? You inadvertently damaged the auriculotemporal nerve. So because you have damaged it, it will repair. So you do know, right? There is a kind of a nerve repair process which is going on. So once this particular nerve repair process starts, there is a possibility that there is a cross innervation. Now, what is this cross innervation? Once this particular nerve is repaired, what can happen? The parasympathetic fibers, which were earlier supplying only to the parotid, now they might also start supplying to the sweat gland. Are you able to appreciate it? So normally the parasympathetic fibers, they were not supplying the sweat glands, but now because of this kind of a regeneration of the nerve, there is a possibility that they will start supplying the sweat glands. And if at all this happens, whenever you eat the food, your parasympathetic nerves will get activated because you want the salivation, but because they are also supplying the sweat glands, they will also lead to the sweating. Okay, I hope you get this particular point. This is what is the reason behind the Frey syndrome, and to diagnose it, the test which we basically order is a starch iodine test. Okay, I hope you get this point. So this is a concept of a Frey syndrome. It is very, very important and you should understand this. Okay, yeah, I hope you got this. Now, pretty simple and a straightforward question. Excision of a ranula. So let's say if at all there is a ranula. Okay, ranula is basically the swelling of the floor of the mouth. It is a swelling of floor of mouth. So what I'm trying to ask you is that what is a nerve injury? Okay, so which is the really sorry, not the nerve. So what is a kind of a structure which can be injured if at all you are going for an excision of ranula? Is it a lingual nerve? Is it a lingual artery, parotid gland, or the submandibular duct? Now you need to understand that the most common structure which is injured when you are basically operating on the ranula is a submandibular duct. Okay, so I'll just write down. Okay, I will not write down. I'll just let you know that the most common structure which is injured in the ranula surgery is a submandibular duct. But let's say if at all somebody asks you what is the most common nerve injured, then your answer will become lingual nerve. Okay, so there are two MCQs in here, guys. The most common structure which is injured, definitely it is a submandibular duct. But if at all somebody asks you what is a nerve which is injured, so it is definitely a lingual nerve. Okay, I hope you got this point right. Okay, great. Now moving on to the next question, guys. So coagulopathy develops during a surgical exploration. The best treatment for the transfusion. Okay, so basically what is happening? Okay, so now let me just elaborate something to you guys. So let's say there is a patient who is coming to you with a polytrauma. So earlier we did not have this particular concept, and what we did was we went in for a kind of a blood transfusion. Obviously we want to go in for a blood transfusion. So earlier mindset was, okay, let's give the whole blood because the patient is kind of losing the whole blood. So if at all you start replacing the fluids with the whole blood, something like that, and let's say this particular patient is requiring 7 or 8 units of the blood or something like that. So because of this, what is going to happen? There will be relative deficit of platelets and clotting factors. Why so? Obviously, right? I mean, because in the whole blood, the kind of the shelf life of this particular whole blood, if at all you use CPD as a kind of anticoagulant, it is close to around 35 to 42 days, right? So if at all you use this, and what is the time for which your platelets and the clotting factors can remain active? That is close to 7 to 10. Because of this, cumulatively, you are going to have a deficit of the platelets and the clotting factors, and because of this, the patients will land up into bleeding. Okay, because you have replaced the blood, but this particular blood is only enriched with WBCs. It is having a relative deficit of the platelet and the clotting factors. This was a major drawback of going in for a massive blood transfusion. So in order to combat this, okay, we definitely need to give the blood to the patient because the patient has lost blood. So that is why we came up with a protocol which is called as the trauma transfusion guidelines. Now, according to this guidelines, what we need to do is that, because now we understand that, because if at all we give only the whole blood, there will be relative deficit of the platelets and FFP, like clotting factors. So now it is said that if at all you want to replenish the blood in the patient with a polytrauma, you have to replace it in the ratio of 1:1:1. So if at all you give one kind of a unit of a RCC, that the red cell concentrate, you have to give 1 FFP and you have to give 1 platelets. Okay. Now I hope I made myself clear, guys. So here the answer is definitely 1:1:1. Now let's move on to the next question, guys. So here, peritoneal bladder rupture and the anterior and posterior urethral injury. So if at all you don't know this, please revise this today. It is very, very important topic. So yeah, let's talk about this. So let's say there is a patient who is suffering from a road traffic accident, and the patient had a pelvic fracture. So patient was suffering from a road traffic accident. Okay, the patient came and you examined, the patient had a pelvic fracture. The patient has no urge to pass the urine since the last 12 hours. Okay, so okay, let's kind of jot this down. There is a patient who came after a polytrauma. Okay, polytrauma ke baad the patient has come to you. When you examine this particular patient, there was a pelvic fracture which was present. Okay, and you asked the patient, okay, do you want to pass the urine? The patient said no. So patient has no urge to pass the urine, and patient has not passed the urine, for how many hours? In this particular question, it is 12 hours. Okay, so it has not passed urine since 12 hours. Okay, right. And okay, so you performed a dye study, and dye study basically revealed the image like this. Okay, so you have the image like this. So what do you think, guys? What is the diagnosis of this particular patient? Is this particular patient suffering from anterior urethral injury, posterior urethral injury, extraperitoneal bladder rupture, or an intraperitoneal bladder rupture? Okay, so if you say that this is a patient who is suffering from an extraperitoneal bladder rupture, you are absolutely correct, guys. Okay, what is the diagnosis? It is an extraperitoneal bladder rupture. Now you can straight away, okay, so now let us break down this particular question. Okay, so I'm sure that you pass urine after every 3-4 hours or something. Why do you go and pass the urine? Because you have the urge. Okay, you have the urge. Why do you get the urge? You get the urge because of bladder distension. Okay, so because of the bladder distension, you are getting the urge to go and pass the urine. Okay, is this possible? Okay, now in this particular patient, if you evaluate, this particular patient has no urge to pass the urine. So what does it tell you? That the bladder is not getting distended. In other words, it is trying to tell you that the patient is suffering from a bladder rupture. So you can basically rule out the anterior and posterior urethral injury just by this. Okay, I hope everybody is on the same page. Because the patient is not having the urge to pass the urine, the patient is having a bladder rupture, right? Okay, so now let us evaluate the bladder rupture. So okay, now you need to understand, you need to remember this, that a pelvic fracture is basically associated with extraperitoneal bladder rupture. Extraperitoneal bladder rupture. Along with this, there can also be another finding. So if at all in the question it has been written that the patient is having a deep perineal hematoma. Deep perineal hematoma. Okay, this is again in the favor of a extraperitoneal bladder rupture. So the two things which you need to look for is a pelvic fracture and a deep perineal hematoma. If at all these two are present, the patient is having an extraperitoneal bladder rupture. Now just by this particular image, you can see that there is a extravasation of dye like this. This is what is called as a flame shaped extravasation. Okay, what is it referred to as? It is referred to as a flame shaped extravasation of the dye. Extravasation of the dye. This is what is called as a flame shaped extravasation of the dye, and this is what is feature of a extraperitoneal bladder rupture. At the same time, what the patient is having, the patient is having a pear shaped bladder. What is patient having? Patient is having a pear shaped bladder. This is again indicative of a extraperitoneal bladder rupture, right? Okay, I hope you get this point. Yeah. So these are the important points regarding the extraperitoneal bladder rupture. If at all the patient would if at all this question would be asking about the intraperitoneal bladder rupture, what would have been in the options? What would have been in the clinical scenario? In the clinical scenario, if they say that there is a patient who is presenting with the peritonitis. If at all the patient says that patient is presenting with the peritonitis, then you say that this is a patient who is suffering from a intraperitoneal bladder rupture. Now somebody is asking what about the urethral injury? So how will you evaluate the urethral injury? So you need to understand that. Okay, so for the urethral injury, what you will get in the scenario is that you will get a palpable bladder. Okay, so you will get a palpable bladder, and you will get that patient has urge is present, but patient is unable to pass the urine. Unable to pass the urine. Okay, I hope you get this point. So if at all you have these two particular kind of things in your option, in your clinical scenario, you will say that okay, this is a patient who might be suffering from a urethral injury. Okay, yeah, cool. I hope you got this point. Right, now let's move on to the next question, guys. So here, by performing, okay, so first of all, I'm trying to show a manure which is present in this particular image. So yeah, just kind of zooming in, you can just have a look at it, what this particular man is trying to do. Okay, so what I'm trying to ask you is that by performing this particular manure, what happened was, the bleeding from the liver. So you performed this because there was a bleeding from the liver, and the bleeding from the liver did not stop even after performing this. So what do you think? What is the source of this particular bleed? Now this is a very, very important concept, guys. I'm sure most of you guys must be knowing that, but yeah, if you're saying that the answer is hepatic vein, you're absolutely correct. Okay, so what I'm trying to show in here, that is what is called as a Pringles manure. Now for understanding the Pringles manure, you need to understand the anatomy. So what you have the liver and you have a duodenum, and there is a ligament which is running from the liver to the duodenum, the duodenal ligament. Okay, what do you have? You have a hepatico-duodenal ligament. Now what is a characteristic feature of this particular ligament? This contains the portal triad. Okay, so this basically contains your bile duct. Okay, no doubt. At the same time, it also contains the portal vein, and it also has hepatic artery. Okay, so are we all on the same page? We are talking about the hepatico-duodenal ligament. There is a ligament which is running from the liver to the kind of the first part of the duodenum, and what is kind of running in over here? In this, you have a portal triad. What are the constituents of the portal triad? So you have a bile duct, you have a portal vein, you have a hepatic artery. Okay, great. Now what you want to do is that, okay, so let's say there is a patient who is coming to you with a liver bleed. Patient is coming to you with a liver bleed. Okay, great. So what you did was you ended up performing a Pringles manure. Pringles manure. What is this Pringles manure? Pringles manure mein you are basically compressing the hepatico-duodenal ligament. Now just let me know, guys, if at all you perform this Pringles manure, and after performing this Pringles manure, two things can happen. If the bleeding from the liver stops, or if the bleeding continues. Now if the bleeding stops, is it safe to say that the source of the blood was either the hepatic artery or a portal vein? Yeah, I think it's safe to say that if at all the bleeding stops, it is safe to say that the source of the bleeding was either the hepatic artery or the portal vein. Yeah, I think it's safe to say that. But if at all, let's say the bleeding continues, what do you think? What is the source of the blood? In this, the source of the blood is a hepatic vein. Okay, I hope you are able to correlate, because the inflow is kind of occluded by you. What is present in this hepatico-duodenal ligament? You have a portal vein and the hepatic artery. So if at all the source of the bleeding is hepatic artery or the portal vein, definitely it is going to stop, right? It is going to stop. But if at all the bleeding is continuing, it means that the source of bleeding is not the hepatic artery or the portal vein, it is a hepatic vein. Okay, so yeah, that is the concept of a Pringles manure. I'm sure you must be knowing it. If you don't, please master this, guys. This is a very, very important concept, and you should definitely remember that. Moving on to the next question. So by performing an endoscopic therapy for the bleeding peptic ulcer, so there's a guy who is having a bleeding peptic ulcer. You did an endoscopic therapy and you found that there is an active oozing of the blood at the base of the ulcer. Okay, active oozing of the blood at the base of the ulcer. What stage of the Forest classification is it? So what I'm trying to ask you is that, what is the Forest classification? So first MCQ, guys, which you got was the Forest classification. Forest classification is basically used for the bleeding peptic ulcer. Okay, it is used for the bleeding peptic ulcer. Please understand this. This is not for the esophageal varices. We are limiting our therapies to the bleeding peptic ulcer. That is what is why you use a Forest classification. So if on the Forest classification you performed an upper GI endoscopy, you found that there is a active oozing of the blood. What do you think? What is the grade? Like, what is the, so if you say that it is a grade 1B, you are absolutely correct, guys. Now this forest classification is very, very important. You need to understand this. Okay, so yeah, now let's kind of talk about this. So okay, so let's say the forest classification, it is basically divided into grade 1. Grade 1, what do we have? In grade 1 you have 1A and you have 1B. What is included in 1A, guys? In 1A there is a pulsatile bleeding. Okay, if at all there is a pulsatile bleeding from the base of the peptide, you have a pulsatile bleeding. In the 1B you have just the oozing of the blood. Now let's talk about the grade. So then you have the grade 2. In the grade 2, what do you have, guys? You have grade 2A, you have grade 2B, and you have grade 2C. What is included in the grade 2A? Here you have a visible vessel. Here you have a visible vessel. So okay, even though the kind of vessel is not bleeding actively, you still can see this particular vessel and it can kind of start bleeding anytime. So that is why these three have a high risk of rebleeding. High risk of rebleeding. Okay, I hope you get this. These have a high risk of rebleeding. What about the 2B, guys? In the 2B, what do you get in the 2B? In the 2B, you have an adherent clot. Adherent clot at the base of the ulcer. In the 2C, what do you get, guys? In the 2C, you have just a pigmentation, or you have a kind of a, yeah, you just have a pigmentation at the base of the ulcer. So it basically says that okay, even though the bleeding is not occurring now, even though you're not seeing any kind of signs of bleeding at this moment of time, but these particular pigments say that okay, there was RBCs which were present, now they have been hemolyzed, and yeah, this is what it basically indicates. And lastly, you have the grade 3. In the grade 3, what do you have? In the grade 3, you have the ulcer with a clean base. So here you have an ulcer with clean base. So what you need to understand is that these have the low risk of rebleeding, and this adherent clot, this is the one which is having the moderate risk of rebleeding. So you need to understand this, guys. Okay, I'm sure I hope this is kind of clear to you guys. This is what is called as a forest classification. So in the forest classification, you basically divide it into grade 1, grade 2 and grade 3. In the grade 1, what do you have? You have 1A, which is having a pulsatile bleeding. 1B, you have the oozing of the blood, and 2A, you have a visible vessel. If you have these three findings, this is what is a person like this. In this particular person, there is a high risk of rebleeding which can occur. If at all you have the grade 2B, that is an adherent clot, in this particular patient there is a moderate risk of rebleeding. And if at all you have the, I'm trying to kind of include this over here. So guys, please understand, if you are saying that it is an esophageal varices, you're wrong. Esophageal varices might look as an attractive option, but that is not correct. The correct answer is definitely a peptic ulcer, guys. Okay, please remember, the most common cause of an upper GI bleeding, no doubt, absolutely, it is a peptic ulcer. Please, please, please do not mark this wrong, because whenever you have an upper GI bleeding and when you try to divide it, you can basically divide it into the non-variceal bleeding, which is constituting 80% of the total upper GI bleeding, guys. Please understand this. And then you have the portal hypertension bleeding, which constitutes 20%. So if you talk about just this portal hypertensive bleeding, no doubt, varices are the most common cause of a portal hypertension bleeding, but this is constituting to kind of less than 20%. I hope you get this point. On the other hand, the non-variceal bleeding, which is the major portion, and if you talk about the peptic ulcer, this is constituting 30 to 40% of the non-variceal bleeding. So ultimately, we can kind of conclude that the most common cause of an upper GI bleed, that is definitely a peptic ulcer, absolutely no doubt about it. Okay, I hope you get this. On the other hand, even the Mallory-Weiss here, this is not a very, very common cause. As you can see, it is only 5 to 10% of the non-variceal bleeding. Okay, so it is an important kind of a table. Please go through it. It is really important, and it is actually a repeat question, but you know, many students tend to answer it wrong. That's why it's sort of covering it. Now guys, let's move on to the testicular tumors. So what is the most common testicular tumor in the 4th decade of the child? Okay, 4th decade of a man. Okay, not a child, right? So what, see, in the testicular tumors, you can basically roughly say that what can be the subtype based on the age, right? So what I'm trying to ask you is that on the 4th decade, let's say if there is a person who is in the 4th decade of the life, what is the most common type of the testicular tumor which he may have? If you say that the answer is seminoma, you're absolutely correct. So let me just kind of elaborate on the age distribution of the testicular tumors. Okay, so what is the most common testicular tumor in the infancy, guys? Okay, in the infancy, if I ask you what is the most common testicular tumor, no doubt the answer is a yolk sac tumor. Okay, what is it? It is a yolk sac tumor. If I ask you what is the most common testicular tumor in the pre-pubertal age group, pre-pubertal age group. So the most common testicular tumor in the pre-pubertal age group is, what is it? Okay, so it is basically a teratoma. If I ask you what is the most common testicular tumor in the adults, or let's say in the second or third decade of life, okay, so what is the most common kind of testicular tumor in the adults? Definitely the answer is seminoma. What is the answer? It is a seminoma. And let's say if I ask you in, let's say, more than 60 years of age, then your answer would be lymphoma. Hope you get this. So depending on the age distribution, you can basically say that these are the various types of the testicular tumors which can occur. Okay, it is important, you need to remember that. Now, pretty simple. Stab knife, which is a basic question of a general surgery, it is used for the incision and drainage. Okay, so what is the number of this particular knife? So what is this surgical blade? This is surgical blade 11. Okay, please understand this. Stab knife is surgical blade 11. This is what is a stab knife, and this drainage, this is used for tracheostomy, and this is also used for arteriotomy. Please remember this, guys. These are important indications of a stab knife. Like, these are the places where we use the stab knife. What about the blade number 15? This is what is a D knife, and we use this where we want to give a precise incision. Okay, so wherever you want to give a precise incision, you basically use this D knife. And these 20 to 23, these can be used for the debridement. Okay, wherever you want to perform a debridement of a tissue, you can basically use this. Surgical blade, surgical knife, it is important. Please go through them. Yeah, at least you should remember the stab knife is kind of 11 and D knife is 15. You should remember that. Okay, do I have any? All right, so a feculent peritonitis is so if you just let me know. Okay, first of all, Hinch's perforated diverticulitis. So what I'm trying to ask you is feculent peritonitis. If at all the patient with the diverticulitis comes to you with the feculent peritonitis, what is the Hinch's classification, right? So is it like type 1, like the class 1, 2, 3 or 4? Okay, so if you say that this is a person who is suffering from a Hinch's type 4, you're absolutely correct. Okay, so what is the answer? It is Hinch's type 4, right? So now let us understand this Hinch's classification, guys. Okay, so it is pretty simple. Again, it is pretty simple. I'll just try to draw a kind of a colon for you guys. So let's say this is your kind of a colonic diverticle or something. So let's say you have a perforated diverticulitis. Now, if at all you have a perforated diverticulitis, what can happen? Either whatever the purulent or the pus is there, it can be localized to this particular part. Okay, so what you can have a localized abscess. Okay, so this is what is called as a type 1 Hinch's classification. Or what can happen, this abscess can basically go from here and it can get deposited in your pelvic cavity, because that is the most dependent part, right? So it can basically go and get deposited in the pelvis, right? So if at all you get a pelvic abscess, I hope it is okay for me to call this as a distant abscess, because it is no more a localized abscess. Okay, so it has gone to a distant location. I can safely call it as a distant abscess. So this is what is a Hinch's type 2. Okay, what is it? It is a Hinch's classification type 2. Then let's say if at all there is a purulent peritonitis. There is a purulent peritonitis. This is what is referred to as Sorry, there was a connection error. I'm really sorry for that. So guys, yeah, if at all there is a peritonitis, this is what is referred to as a Hinch's type 3. Okay, so this is what is referred to as a Hinch's type 3. And lastly, if at all you get a feculent peritonitis, this is what is called as a Hinch's type 4. Okay, so I hope you get this particular point, guys. This is important. So these are what you basically have a Hinch's classification system, right? Yeah. So that is what you need to understand. Why is this important? Because on the basis of this, you can basically kind of classify your diverticulitis and you can manage these particular patients accordingly. That's it, guys. That's it for today. I hope this particular session was helpful to you in some way. I am going to break for now. I'm going to have another AM. Okay, so it means like just after 5 to 10 minutes, I'll be joining again. So you can basically have a link as what we call it as rapid fire MCQs in surgery episode 2. Yeah, that is what you will be having in the same YouTube channel. If you wish to come and attend it, again, we'll be discussing around 10 to 15 MCQs. If you want, you can definitely come and join me up. And yeah, guys, if at all you're liking this particular MCQ discussion with me, what I've decided is the general surgery system wise, like in total there is going to be around 44 hours of the session, and in this I'll be revising the entire general surgery system wise in the form of the MCQs. Okay, so if at all you want, there is one course which I'm launching. This is going to start on the 1st of September. If at all you're remotely interested into this, you can just go and check it out along with all the awesome courses which are basically present on this particular platform by all the other educators. You can definitely go and check it out. And if at all you wish to revise general surgery, I assure you, like, it is going to be a system-wise revision and entire general surgery is going to be revised in the form of MCQs. So yeah, if at all you're a Plus subscriber, please do not miss this up. Do come and attend it. And if at all you're not, if you want to kind of come and attend this, please do consider joining it up. If you wish to join it, you can consider using my promo code which is present in the description box, that is tr.pawan, or you can use drpawan whatever, like you can basically use that, right? And yeah, thank you so much, guys. If you have anything to ask me, definitely feel free to ask me, and if not, let's connect again at 10 AM. I'll be more than happy to connect with you. See you. Have a great